Welcome everybody to the Independent Sage Friday briefing. We're now a year into the pandemic. A year ago, the death toll had just passed 1,000, and now coronavirus has taken the lives of almost 150,000 people in the UK. We're grieving for those lives lost, many of which we know could have been saved had things been handled differently. We're also grieving for time spent away from loved ones, for the disruption to normal life, and for the social and economic damage that has happened. But there are reasons to be hopeful now. Half of all adults in the UK have now had their first dose of the vaccine. The question of vaccine passports has loomed large in the national conversation this week, together with discussions about the ethics of that. And vaccines for children have also been mentioned. And as other European countries experience yet another rising wave of infections, can we escape that in the UK? Of course, as always, we have a lot to get through, and it is our tradition to start off with a roundup of the latest figures this week from Dr. Kit Yates. Kit, over to you.
Thanks. Sorry, just trying to find the unmute button once I'd shared screen. So hopefully you can all see that. Okay, so these are the latest numbers up to this week. Here are the headlines. So cases seem to have stagnated. They seem to be flatlining at the moment. Deaths are continuing to fall rapidly, which reflected the previous falls in cases. Vaccines, the rate of first doses is slowing down a little bit, but we're doing more second doses. We've had a bit of a slowdown this week overall. And actually, we're going to have a little look at Europe today, which many countries in Europe are seeing a third wave. So this is the order I'll take you through in. First, we'll look at cases, and then I'm going to have a little look at age-related data and see what I can infer about the impact of schools going back in England and a little bit in Scotland as well. I'm going to touch on critical care occupancy, because that's actually a really good news story at the moment. Talk about deaths, vaccination, and potential problems from variants. And then I'll finish by looking at Europe. So in terms of cases, positivity, so cases are now pretty flat across the UK. They've been falling for a while, but if you zoom in now, you can really see just how flat they have been in the last week or so. You can see that there has been perhaps a slight increase in the last week. But cases, it's arguable, as always, green here are the confirmed cases and black is the 7-day rolling average. As always, it's arguable as to how much of that increase could be due to increased testing. We know we've been doing a lot of increased lateral flow device tests as children have been going back to school. So we try to look at the positivity rates. So these are the case rates by different nation. So these are by specimen date, so when people had a test. And again, it paints a picture across all 4 nations. So red is England, black is Northern Ireland, green is Wales, and blue is Scotland, of cases that are flatlining, possibly rising in Scotland. But looking at the positivity rates, so taking the number of people who test positive and dividing by the number of tests that are done, it seems that things are still going down across all 4 nations. Now, this is slightly at odds with the data that came out from the Office for National Statistics today, which probably at the moment is to be slightly more trusted than the case data, because there's so much going on with different types of tests and different testing that's going on. So the Office for National Statistics in England suggests that cases are pretty much flatlining. This is incidence data now, not just prevalence data that we've seen before. So this is the number of new cases per 100,000, per 10,000 people per day. So ONS suggesting that is now either flat or increasing. Similarly, in Wales, it seems to be fairly flat. Northern Ireland seems to be seeing increases, and Scotland has seen increases for the last couple of weeks, 3 weeks maybe in a row, which perhaps reflects the fact that their schools went back slightly earlier. So I think that ONS, as we always say, is probably our gold standard data source, and that's probably the one that we're going to be looking at the moment the most as the most reliable indicator. Although, of course, we also have to bear in mind that it's potentially small sample sizes in the ONS survey. Again, looking at the English case rates by region, you can see again the same picture. It appears to be flatlining across all of the English regions at the moment, so very, very steady. Again, looking at positivity rates, you see this fall, this very small gradual fall recently in positivity rates across all regions, which again, the ONS survey suggests things are a bit more mixed than that. So it's really difficult to say at the moment exactly what's happening across all the different nations and the different regions. I think what's probably happening is that cases are probably about flat, and that may be an effect of schools, and we still probably haven't seen the full impact of schools yet, so we need to keep an eye on that. So on that note, I'm going to break down some of this case data by age. So just looking at the over 60s, then you can see that the case data is falling quite nicely in all of those age ranges. And then similarly for the 20 to 59 age bracket, you're still seeing falls or flatlining more recently in all of these different regions. But if we now look across the different regions at the under 20s, since the 8th of March, you can see that there have been increases in all regions, most notably in Yorkshire and the Humber. So this is for the everyone under age 20, which is obviously a huge range of different people. It incorporates preschool, school-aged children, and adults, young adults who have left school. So I've broken this down a little bit more into 4 different age categories of 5 years each. So blue is 0 to 4, orange is 5 to 9, grey is 10 to 14, and yellow is 15 to 19. And it's quite clear to see in this case data, so this is cases per 100,000 per week, it's quite clear to see that the two groups that are rising the most are 5 to 9s, which roughly corresponds to primary school, and 10 to 14s, which roughly corresponds to secondary school. Obviously, there's some overlap there. 0 to 4s are flat or falling, if anything, and 15 to 19s are relatively flat as well. But clearly in these two age cohorts that are dominated by school-aged children, you can see that there's been increases which coincide with schools going back on the 8th of March. So whilst this isn't proof of schools driving transmission, it is consistent with transmission in schools. And looking at the ONS data, similar sort of picture is painted. So this is now prevalent. So the left-hand plot here is age 2 to school year 6, so primary school and nursery school, and you can see sort of flat or slight rises in that age group. Years 7 to 11, so secondary school, you can see increases over the last week, and again it coincides with roughly when schools went back in England, and then you can see year 12 up to age 24, so a bigger age category now, including if they are students, university age students, you can see falls in the prevalence there. But with the school age children, you can start to see these rises that we were expecting, given what the modelling was suggesting about what would happen when schools go back. This is just case data that I've showed you, although the ONS data is a random sample, so we can be more confident in that. So could those rises that we've seen be due to rises in testing? Well, certainly there has been huge rise in testing since mid-February this is the use of lateral flow device tests, but actually since the week after schools went back, the level of lateral flow device testing has been pretty much constant. And so it suggests that these rises that we're seeing in these school age cohorts are genuine rises, not just rises that are due to increases in testing. And this is data from the Public Health England. This is looking at weekly confirmed cases per 100,000 in primary age children, excuse me, since the start of the year. And again, you can see that in the last 2 weeks, so weeks 10 and 11, the dark blue and the dashed line bars in each of these different age cohorts from nursery, preschool, reception up to year 6, you can see that there's been increases first in the dark blue week in week 10 when schools went back, and then again in week 11, which was not this week we've just had, but the week before that. And so you can see there's been marked increases week on week since schools went back in all of these age cohorts. Secondary schools is a little bit different. You saw increases in the first week in this week 10 here data, quite big increases in fact, but then you've sort of seen a leveling off or perhaps a dropping in the most recent week, which might be indicative of the fact that lateral flow tests are now being done at home, and also a confirmatory positive PCR test is required, so that actually maybe we're seeing fewer false positives. But anyway, we have definitely seen rises since schools went back, both in primary and secondary school age children. And then this last piece of data is again from Public Health England, which is looking at clusters or outbreaks in educational settings in England. You saw when schools went back in January, when 25% of primary school children were in schools, we saw these large increases in the number of outbreaks. That dropped slowly over time, reflecting the drops that we were seeing in cases in the community. But then again, since schools have gone back in week 10, we're starting to see these increases in the number of outbreaks in educational settings again, and most notably in this data in primary schools. That's the large majority, which sort of reflects what you're seeing in the other age charts for Public Health England. And then finally, just talking about Scottish data, we have been seeing rises in age 0 to 14 category since around the 22nd of February, when primary schools went back in Scotland. That seems to be leveling off a little bit, and indeed we've seen small rises in 15 to 19-year-olds more recently, but it's flatter in the older age groups. And similarly in the even older age groups, so 45 and above, you can see that there's been fairly continuous falls, although it's flattening off a little bit. But again, there's evidence to suggest that schools are contributing to transmission, at least in school age children, potentially in older age groups as well. So a little bit of good news now about critical care bed occupancy. So these charts you'll be getting familiar with, but I'll remind you that the orange dot shows where each region was this week, and the grey dot is the week before. So if the orange dot is above the grey dot, it means that critical care bed occupancy percentage has increased, and if it's below, like in the Midlands, then it means it's decreased. Pretty much everywhere is staying roughly stable. There's been some falls over here in the southwest and the northeast and Yorkshire and the northwest, but the really good news is that everywhere now is below 80% of capacity, which is what we would hope to be running critical care units at the very most, 80% capacity. So it's good that all of the critical care bed occupancies have decreased below 80% now. And similarly, looking at changes over time, so here blue is this year, orange is the previous year. The full line is the capacity, and the dashed line is the occupancy. You can see that the occupancy is now getting down towards levels which we saw this time last year, and similarly that's now allowing us to decrease the capacity. So to give hospitals back their normal function, they had to change lots of things in order to increase critical care capacity, as you've seen, to deal with that huge hump of cases that we saw over January and February, and now that is also coming back down again, so we're allowing hospitals to return to their normal function, which can only be good news. So that's a short good news thread. Deaths also, we're seeing sustained falls which match the falls in cases. This is across the whole of the UK now. From this huge peak that we had in the middle of January, we're seeing big falls, and that's slowing down a little bit now, but we've seen really good falls, so it's good to see that deaths are coming down. And again, this is reflected in probably what's the gold standard of death data, which is looking at deaths registered on death certificates. You can see that we've seen week-on-week falls since the peak. This data is for the week ending the 12th of March, so it's a couple of weeks out of date, and we can expect to see deaths to continue to fall over the next few weeks. It's been a week of people insisting on having flags all over the place, so I thought I would put a couple of flags in this Independent Sage briefing. I'm also going to include some other flags as well. These are flags of various different nations who unfortunately have not done particularly well when it's come to deaths. So this top line is ranked in order cumulative COVID-19 deaths. So UK UK sits 5th on that list, behind some countries which have far higher populations than the UK, so United States, Brazil, Mexico, and India. And even if you normalize by the size of the population, so you look at the deaths per million or the deaths per capita, then you see that the UK still sits 7th on that list, behind some of these other European nations here. So whichever way you look at it, the United Kingdom has not done particularly well when it comes to deaths, reflecting over the previous year. I'm going to talk a bit about vaccinations. So vaccination is a shining light. It's still going very well. We've seen a bit of a slowdown this week in terms of the total number of doses given. First doses have started to drop off. We're still doing lots of second doses now, and we're going to continue to see second doses dominate the number of doses that are being given as we move into April and we face supply issues in the UK. So we are still doing lots of vaccination, and that's fantastic. We are going to stop doing first doses so much in April and start ramping up the second doses to make sure that we keep pace with the people who were vaccinated 12 weeks ago. Again, looking at first doses given as a proportion of the adult population, we're now up above half the adult population, so over 53%, excuse me. And second doses given are up to 5% now, so that's good. We're seeing these continual rises, but this will, as I said, this will flatten off for a while, this first doses, as we just focus on giving second doses in April. Looking at the different nations, again, roughly similar sorts of percentages of the adult population vaccinated in each nation, although you can start to see a bit of a disparity. England is surging ahead and Northern Ireland is falling behind a little bit. So we'll have to keep an eye on that and try to make sure that everything stays roughly equal across the United Kingdom. Looking at first and second dose coverage across different age ranges, you can see that in the over 80s, we have vaccinated we've given a very high proportion of first doses to the over 80s, and we're starting to give higher proportions of second doses to the over 80s as well. Really good coverage in the 75s to 79s, and that's dropping off, but this is more a reflection of the fact that we just haven't got round to vaccinating these people rather than vaccine hesitancy or anything like that. And then just looking specifically at the over 80s, this is something we just need to keep our eye on a little bit. So this is 11 weeks ago, we'd given 23% of first doses. Currently, 11 weeks later, we've given 26% of second doses, which is great. We obviously need to keep that up, but we need to make sure that we stay ahead of this curve with the second doses. So currently we're about a week ahead of where we need to be with giving second doses. That's really good, but we need to make sure we ramp up giving second doses so that everyone gets their second dose within 12 weeks of having their first dose, which means we need to ramp up giving second doses in line with how we ramped up giving first doses. I just wanted to look a little bit about vaccine hesitancy. This is a survey done by the Office for National Statistics. We've talked about a bit recently on Independent Sage, deprivation gradients. So this is ranking the proportion of people who suggested they would be vaccine hesitant. So that includes people who answered the survey who've either been offered the vaccine but declined, people who are unlikely to have it if offered it, people who said they were neither unlikely or likely, or people who didn't know or preferred not to say. So in the most deprived areas of the UK, 16% of people were vaccine hesitant by this definition, whereas in the least deprived areas it was as low as 7%. So you can see this gradient is something we need to try to level up if we can, to put resources into convincing people that the vaccines are safe and that they should be having them, because otherwise we're going to see more entrenched inequality, COVID related or non-COVID related inequality. Similarly, looking at ethnicity as well, you can see there's a stark difference between the proportion of people who are saying that they're vaccine hesitant by ethnicity, with it being as low as 8% in white people and as high as 44% in black people. So we need to be, again, really careful that we don't allow COVID to become a disease of inequality, and to allow COVID to disproportionately affect different communities because they are not getting vaccinated. So we need to concentrate our efforts on that. Lastly, I'm going to look at the situation in Europe. We are seeing a third wave in Europe, in particular in some of the countries I've highlighted here, like France, Poland, Italy, and Germany. Netherlands are starting to take off as well, although I should be careful to say that it's not in every country in Europe. So Spain are bucking that trend, and obviously the United Kingdom ourselves, we're going against that trend as well. But this is really a function of the fact that these countries are now dealing with higher proportions of B117, the UK variant. So it's much more transmissible, which means that the measures that they were taking before aren't working, and they need to institute new measures. So as for Boris Johnson saying we need to be careful that this third wave doesn't wash up on our shores, I think it's probably the other way around, that our second wave has now washed up in Europe, if you like. And actually, there's no reason why cases would rise in the UK just because they're rising in Europe. If cases do rise in the UK, it will be because we have released restrictions and allowed the reproduction number to get above 1, or potentially because we've imported a variant which is less affected by the vaccines. Again, this is just looking at cumulative deaths. So although other countries are having another wave, the United Kingdom is still way out ahead in terms of major European countries, in terms of the death toll. Although, of course, the United Kingdom's death rate has flattened off recently, whereas many of these other countries are now seeing rises corresponding to the rises in cases that they're seeing. This is vaccination, and this is the race now, is to try to get people vaccinated as fast as possible, faster than people can catch and die from COVID. And again, you can see the United Kingdom is doing an incredibly good job on vaccination compared to European neighbours. Of course, we've largely delivered first doses, but even if you halve the number of doses that we've delivered, you can see that we're doing better than many of our European neighbours. So the one real concern, I think, despite our vaccination program, is that we potentially might import these variants of concern. So this is a chart showing the cumulative number of variants of concern that have been genomically confirmed. So they've been sequenced in the United Kingdom, and you can see this steady rise in this South African numbers of the South African variant that have been detected, and perhaps also worryingly this increase down here in this Manaus P1 variant from Brazil. We're particularly worried about the South African variant because it's been shown to evade, if you like, some of the vaccines that we have, and obviously allowing these variants into the country and to spread would undo a lot of the great work that we've done in the vaccination program. So far, we've been fortunate in that, these variants have been arriving when we've been in lockdown. So the reproduction number has been below 1 and chains of transmission have naturally been broken. But as we start to open up, that will no longer be the case. And so we need to be really, really careful about where we're allowing people into the country without managed isolation from, in order that we don't import these variants, which potentially will undo the good work that we've done. So just to summarize then, it looks like cases have flatlined, and looking at the age segregated data, seems to be that cases are rising in school age children, but at the moment are still falling in other age groups. Critical care unit occupancy is approaching normal levels, which is really good news. Hospitals can start get back to normal and start to shift some of these backlogs that have built up. Deaths are also very low, lowest levels since October, so that's really good news. Vaccine delivery is also going well. We've seen a bit of a slowdown, but we're also going to see more of a dramatic slowdown in April when we have supply issues and we just have to focus on giving second doses, which means that for a longer period of time, more people will remain unprotected, and that's potentially worrying as we start to open up. It's true that Europe is seeing another wave, but there's no reason to believe, as Boris Johnson suggested, that this will wash up on our shores unless it's due to our own carelessness. And finally, I think probably the most important thing at the moment is that these variants pose a real threat to our vaccination program. And of course, that means a threat to the roadmap. So we should be doing everything we can to try to reduce the possibility of these variants, firstly, coming into the country, and secondly, spreading once they get here. So yeah, that's it from me. Thanks.
Thank you very much indeed, Kit. Now, we do have a report from one of our special guests, Stephanie Hare, who's a tech ethicist, talking about the vaccine passport. But I'm going to start with a question before we come to you, Stephanie, from our special guest, Shadow Health Secretary, Jonathan Ashworth. So, Jonathan, what is your question?
I appreciate that, Alice, because I've got other appointments to get to. So sorry, but excellent presentation, and thank you all to the IndySage team for your ongoing brilliant analysis and advice and contribution to the public debate. My question is about passports. Would a passport, a vaccine passport, a COVID test passport that appears to be being talked about, allow large-scale events to go ahead after the roadmap lockdowns have been eased? Would it allow socializing in hospitality to go ahead safely? Or if we get to a situation where we have relatively high levels of vaccination across the population anyway, would that mean that it becomes irrelevant what your vaccination status is?
Thank you very much, Jonathan. And we will have that report from Stephanie shortly. So we will be broadening this out to talk about the ethical side of vaccine passports there. But if we could stick to the more operational, logistical side of that question, that would be fantastic. Who would like to talk about that? Professor Anthony Costello.
Thanks for the question, Jonathan. I'm not going to answer the specifics. I just want to start by saying the reason I'm opposed to vaccine passports is I believe it implies that we're either just going to have a vaccine rollout or a lockdown policy and not pay any attention to trying to suppress outbreaks of the virus and manage it by mass testing and passports and things. And you've been arguing for this over the last year in the Houses of Parliament, and we've been arguing it in IndySage. Now, look, there are two broad measures to control this virus: population immunity, and we're doing really well on our vaccine. But the other is the public health measures of rapidly finding cases, isolating them quickly, getting test results back quickly, having enough contact tracers on the ground. And if we follow the experience of Asia and general rules on community health workers, it's around usually between 1 in 1,000 to 1 in 1,500, one worker to that population. And if you want to fight a war, you need an army. And I rang or spoke to actually communicated by email with a northern district recently, and they have 19 contact tracers when they should have over 100. And all of it is funded from their routine public health budgets. Nothing comes from the 37 billion. So we're doing very badly, and we have consistently done that, and you know this well, and we know this well. Now, I think it was last week that Chris Whitty said, we are going to have surges, and the modelers are saying we're going to have a third surge. And Sir Patrick Vallance said, look, as cases fall, find, test, trace, isolate becomes important. So my thing is, why are we neglecting public health measures still? Why have we not learned our lessons from the successful countries? And why are we risking further lockdowns, which are incredibly damaging? We're against lockdowns. And so for that reason, I would forget passports, because implied in that is this policy.
Thank you, Anthony. Professor Susan Mickey, you have a response here.
Yes, there are several ethical issues, but I know Stephanie's going to come in on that, so I won't touch on that. But there's various other kind of problems about this. One is psychological. If you have a passport showing that you're vaccinated, so you're all right to go into all these risky settings, then it gives a false sense of reassurance to people, because we know that vaccination will only be partially protective, and we don't know how much it will prevent onward transmission. Secondly, there is an operational issue about who's going to monitor this, who's going to enforce it. And we know from recent data that all those collecting of addresses and phone numbers, etc., in pubs and restaurants previously were just not used at all. And the third thing is that this is a big distraction, pushing things on to the individual rather than sorting out the environments. And we should be making sure there are safe hospitality venues wherever people go, whether or not they've been vaccinated.
Thank you very much, Susan. And now Dr. Tallulah Oni and then Professor Stephen Reicher. Tallulah.
Thanks. Yes, I will end what I'm about to say with the same point that both Anthony and Susan have made around the opportunity cost. But I do think it's important when we talk about vaccine passports, because it's this umbrella term being used, and to consider, are we talking about something that for domestic use versus overseas travel? Are we talking about something that's in context of employment versus particular venues versus other domestic use? In the context of employment, are we talking about within the healthcare context or health and social care context versus other public facing employment versus general occupation use? So I think those have different implications and those have different purposes. So, and that really addresses the why of what is the purpose of the vaccination passport. Relatedly, is it to show that we have certification? It's important to clarify if it's covertly as a nudge trying to improve vaccination uptake. And I think that is important because there is a little bit of a tension there, because that bypasses the need to address people's often valid concerns around the vaccines that need to be addressed head on rather than covertly forcing vaccination uptake, which I think could have unintended consequences. The how of the certification, so what is being put in place, how interoperable is it in different contexts, and is this like for like, what is it measuring, who's responsible for the accountability, what are the data sharing and privacy implications. So when you add all of that, coming back to Anthony and Susan's context, points about the opportunity costs, right? If we're not clear about all of those questions, not to mention the ethical issues, what else could we be doing to ensure that we are protecting health and doing so equitably? And as Anthony mentions, the really critical things of knowing that we're doing well with vaccination uptake, but knowing that we will get these surges, what are the things that we need to be doing to address that at a local level? And we know what we need to do, which is engaging with the community at a local level of finding, testing and tracing and supporting people. So ultimately, it comes back to that particular point. Thank you.
Thank you very much, Tolly, and Professor Stephen Reicher.
So let me add to this litany of arguments as to why vaccine passports are a daft idea and I think an own goal. Although, first of all, Tolly was completely right. We've got to distinguish between different uses. If you look at the polling, for instance, most of the public will accept vaccine passports for going abroad. They also will accept the idea that if you're working with vulnerable people, for instance, it's a good idea to be vaccinated. But when it comes to demanding vaccine certification to take part in everyday life, whether it's going to the pub, going out socially, going to work, then most of the public are against it. What's more, there is a body of research which looks at what the impact is on take-up of the vaccine. And the government's argument is it's an incentive, it will get more people to be vaccinated. But in fact, the studies show that particularly for those who are reticent, making it compulsory either has no effect or is counterproductive. There's a German study which shows that it leads to greater anger and to lower take-up. And the point, in a sense, is clear. One of the concerns that some people have is that vaccination isn't for us, it's to control us. And if you make vaccines compulsory, of course, it feeds into that narrative and therefore it reinforces their reticence. So at a point where we should be going to people, persuading them that the vaccine is for their own good, to do something which alienates people and makes them feel that the vaccine is being used against them is a deeply and profoundly counterproductive idea. It is likely to lower take-up when absolutely we need to increase take-up. And the second point I want to raise is that about the logistics of how you would use this. So imagine a situation where a large number of people are going to the pub and that you begin to demand that they have certification. And you look particularly to those groups who are less likely to be have the vaccine. So you begin to get stop and search. And that stop and search is used particularly against minority groups, deprived groups, ethnic minorities. And we know the impact of stop and search on community relations and the public good. If you wanted to look at the factor which best predicted which boroughs in London had riots in 2011, you looked at the stop and search rates over the previous year. So again, it threatens to disrupt community, to create social disorder. So I think in a whole series of ways, this notion of vaccine passports, we shouldn't even be talking about it right now. We should be putting all our efforts into maximizing the levels of vaccination. And if we did that, then the notion of vaccination passport would be redundant, because if everybody's vaccinated, you don't need a passport.
Thank you very much, Stephen. I think at this point we should bring an ethicist in, and we have Stephanie Hare, who is a tech ethicist here, to talk to us specifically about the vaccine passport. Stephanie, over to you.
Yes, hello. Thanks everybody for letting me join you today. I'm here to discuss the ethical implications, and I approach this from the perspective of technology because somebody's going to have to build this system. And the track record that the United Kingdom has had on digital health initiatives in this pandemic leaves a lot to be desired. There's a lot that we could learn from that. So we're looking at contact tracing apps. We know about the issues with accessibility and performance for that. Privacy considerations, of course. The QR code scanning discussion, which showed that the government wasn't actually using the data, and people who were exposed to the risk of infection hadn't been told. That was reported quite recently. There's an accessibility for people who don't have smartphones. There's the question of who would have access to the data, who's going to build it out, and even if a facial recognition technology could be used. That's one of the 8 pilots that the government has been funding to trial vaccine passports. One of them has a facial recognition component. So you can see very quickly we're going from this idea of what can we do to make it so that people can go to the pub, which is certainly one problem that we could try to solve here as a country. Or are we really now saying we're going to introduce an identity card nationally by stealth? Only that identity card is far more significant than anything we considered back in the early 2000s when the Labour government brought it in. And then when the Liberal Democrat Conservative coalition got rid of it in 2010, we'll all recall, Boris Johnson had said if he was ever asked to produce an identity card, he would eat it. What's going to happen now if we go ahead with vaccine passports is we would have effectively an ID card that is linked to your health status. Now, that's an incredible leap for this country that has never had a national identity card system. And it really raises all sorts of ethical issues about enforcement. We know, for instance, that pregnant women are likely to not want to take up the vaccine, and in many cases are advised not to. And that's a personal choice for them. We know that there are all sorts of communities, not just young people, but different communities in this country that have a hesitancy, not a reluctance or an anti-vax position, but just a hesitancy towards getting vaccinated, who suddenly could not only be shut out of the pub, but rejoining civic life or even potentially going back to work. They have to go to their jobs. So by the government saying we might leave this up to pub landlords or employers and failing to take a leadership issue on this, what they're really doing is just leaving this open to create a civil liberties disaster, really, because you're going to have all sorts of questions about employment law and workers' rights and discrimination lawsuits. And the people who end up paying for that are taxpayers, because we'll have to fund all of those lawsuits being adjudicated. It would be better if we just came up with a position as a country. And if we are going to do this, we're going to have to introduce primary legislation to cover for all of these cases and eventualities. So what concerns me at the moment is that we've seen the government do a complete 180 on this idea of vaccine passports without giving any explanation as to why. So there's a public communication messaging snafu there and some sort of disconnect. So back in December, you'll recall that Cabinet Office Minister Michael Gove said that there were no plans for a vaccine passport. And then in February, the vaccine minister, Nadeem Nazawi, ruled them out. He said they would be discriminatory because it's not compulsory for people to get the vaccine. And crucially, it's unclear what impact vaccine passports would have on transmission of the virus. So that's a key point. Boris Johnson obviously said we wouldn't need them to go to the pub. We need to therefore answer some key questions. And I'm so grateful that we have scientists on this call who can answer this. So first is, how long does immunity last, whether from having COVID-19 or from having been vaccinated? And do vaccines stop transmission of the virus, including against variants such as the South African variant? because we would need to know if a vaccine passport, we roll the system out, actually helps to solve our problem. And the problem isn't going to the pub. The problem is breaking the chain of transmission. Thank you very much.
Thank you very much indeed, Stephanie, for all of those insights, but also those questions. And thank you for joining us today. So could we pick up Stephanie's 2 questions? How long does immunity last from vaccination? Do we know indeed? And does vaccination provide, what is the level of immunity that vaccination provides? So who could I come to for an answer to these questions? Gabriel, we haven't heard from you yet. Deenan, Professor Deenan Pillay, virologist.
Thank you, and thank you, Stephanie. I think the whole discussion is really important. I think the answers to your question are quite straightforward. First of all, we don't know how long immunity lasts because the trials have only just been done of the vaccines, and we haven't been able to follow up people for a long period of time. It's a reflection of the fact that compared to other vaccines, which generally take 10 to 15 years from first inception through to actually roll out, it's taken a year to do this one. So I think that's implicit there. So we don't know that. And secondly, whether it stops transmission, I think it's likely to have some impact on that. But the precise, it certainly may not be stopping transmission by 100%. In other words, it may move a symptomatic infection to an asymptomatic infection, which is good for you as an individual, but nevertheless will not necessarily stop you transmitting. But I should say, just in the terms of the context, I do think it's, whilst those questions are important, I think this policy about a vaccine passport should not live or die by answers to those questions. What the policy is there to do is almost, in a crude sense, is a way of getting parts of the economy going, and actually in providing some other notional incentive for vaccinations. And we've heard from many of my colleagues about reasons why that's not. And so I think that is really the key question, is about how best to get vaccination rolled out at the same time as minimizing transmission of infection, rather than the vaccine passport being based around some empirical sort of facts about how long immunity lasts. Thanks.
Thank you very much, Dean. And Dr. Zubaida Haque, you'd like to comment here?
Well, thank you very much, Stephanie. You have raised, I think, some of the most fundamental questions about the vaccine passport. And you're absolutely right to say that at the moment it's being presented as something innocuous. So I think the Sun put it as jabs for pubs, as though that's all it is, when we know very well that this is a slippery slope, that it starts with access to the pubs and it can end up with, can your employer turn you away because you haven't been vaccinated? And more importantly, can your employer, can your bank, can anyone have access to all your private medical data? Now, those are fundamental questions. And I think it's also important, and as you rightly point out, to ask, is this the Prime Minister's way of getting ID in through the back door? And we know ID is a huge problem in this country. Some 11 million people in this country don't have voter ID, don't have photo ID, which is a huge problem because the Prime Minister is also trying to introduce voter ID. And we know that voter ID is a way of suppressing votes. So we absolutely need to say no to this, because this is a backdoor way into ID, and that's unacceptable in this country.
Thank you very much, Zubaida, and thank you again, Stephanie. I hope you're going to stay with us, because I'm sure there will be more ethical discussion as we move on now. And we're now going to take a question from Nigel Nelson from the Sunday People. Nigel, are you there?
I am indeed. Thanks, Alice. Just going on to what you were saying earlier, does this mean that it is madness to even think about booking a summer holiday abroad this year? And should we also, because of transmission, be thinking twice about even staycations?
Thank you very much, Nigel. How mad is it to think about going abroad? How mad is it to think about going somewhere else in the UK? Christina Pargle, Professor Christina Pargle.
So I think it's very risky to book a foreign holiday. I think it's quite possible that the UK government will put in restrictions on where you can travel from or to. Now, whether they do or not, I don't think we should. I think this is going to be the year of the variants, and I think, you know, the best chance that the UK has of not having a disastrous new wave is to avoid the growth of new variants here that could threaten our vaccination program. And the safest way to do that is not to have international travel this summer. As far as I know, within the UK, what new variants have been tracked kind of in various places, it doesn't seem like there is a big kind of geographical difference there. If there does start to be a pocket of new variants, then yes, I think we'd have to think about domestic travel as well. But that hasn't happened yet.
Thank you, Christina. Does anybody else want to comment on holidays? Professor Cole Friston.
Well, just to endorse Christina's point about foreign travel, I certainly wouldn't book an international holiday. However, the modelling does suggest that there will be either a big or a very muted wave, fourth wave. Most of the modelling from Warwick and Imperial suggests that's going to be in the autumn, and that certainly concurs with the UCL modelling. All of them suggest that in the UK, we're probably going to return to levels of prevalence and incidence that we enjoyed last summer, which means that I have booked a staycation. So I would be optimistic that we will enjoy a summer which is not unlike last summer. And that's not to say that there will be worries as we move into autumn. Just technically, one issue with a lot of this modelling in terms of long-term forecasting for sort of holiday plans and the like, that's the issue of variance is clearly very prescient, and and it's very difficult to predict what's going to happen in terms of the variants changing transmissibility, but we can predict a decrease in transmission risk that has a seasonal component, and it's that seasonal component that lends a shape to the prevalence and the trajectory, which we can predict with greater accuracy. So I'll just conclude by saying that it's likely that we will have a window of staycation opportunities in the summer of this year.
Thank you very much, Carl. And Professor Anthony Costello, you wanted to comment here.
Yeah, don't go abroad, stay in the UK. We've got fantastic places. I went to Scotland for the first time for donkey's years last year, and it was unbelievable. The most beautiful place I've been. Wales is lovely, the Lake District, Ireland. I think we should support our bed and breakfasts, our outdoor restaurants, our coastal communities, everything like that. I would certainly book and plan to, well, I'm in Yorkshire at the moment. I'll be back in Yorkshire in the summer. But I think all the odds are, as Carl says, that, July, August is going to be pretty good, and go for it. That would be my advice.
Thank you very much, Anthony. I might head up to the Hebrides again. I think Claire Fox is going abroad, though, isn't she? Professor Dean and Pillay, you wanted to comment here too.
I think Anthony's missing the Union Jack on the wall behind him. Listen, I think this is a difficult issue for many people, and I don't think we as independent SAGE, my colleagues, we should just be characterized as no, you've got to stay at home or not go far. We've got to recognize there's many reasons why people go abroad. it's not just for holidays. It's going to see family. It's, you know, we have large numbers of people in the UK with all family elsewhere in the world, not necessarily Europe, but around the world. And there are many different motivations for people for travel, and people have not been able to do that for a year. So I think we just need to be a bit sensitive about this, not just assume people are going to want to lie on a beach in the Greek island or the Costa Brava or wherever it is. There are many other reasons, but nevertheless, obviously, scientifically, I think I would agree that we're at a critical point, as there have been many critical points during the pandemic. And I think border controls, one of the things that have been weakest within the UK and has contributed to ongoing transmission. So that would be a scientific view. But on the other hand, I think we also need to have some level of sensitivity to the different requirements of the people within our communities.
Thank you very much, Dean, and thank you for that question, Nigel. Moving on now to a question coming in from Connor Riches. Connor.
Hi there. So my question is about long COVID and vaccines. There are news reports that vaccines have cured or improved the symptoms of some of those with long COVID. This is brilliant. But you know, in the long COVID support group, there's a thread where people can actually report the outcomes once they've had their vaccine. Both for the usual side effects, but also side effects of their long COVID afterwards. We've got well over 1,000 replies. I think it was 1,300 replies at the moment, with a range of outcomes, good, neutral, and unfortunately there have been some where, you know, people have had a relapse or a worsening of symptoms, and you know, this is a huge worry as someone who's actually got long COVID and who's dealing with this. This is a massive worry. You know, relapse isn't just feeling a bit poorly, it's debilitating. It's emotionally and physically devastating. And personally speaking, I don't think I can do another one. I really don't think I can. I've been ill since July 2020. You know, I'm feeling the best I've actually felt since I got ill, which is great. But you know, the thought of another relapse is extremely worrying. So my question is, you know, what might be causing these reports of both improvement and you know, what could be going on there? Is there any assurances that can be given as well? Thank you.
Thank you very much, Connor. So do we know of any ongoing research looking at long COVID and vaccination? Who would like to start with this one? Dr. Kit Yates.
So I don't know about research into long COVID and vaccination. One thing that would have to be taken into account really carefully with this is reversion to the mean. So if someone's feeling bad when they get their vaccination and then they start feeling better, they might try and attribute to that to the vaccine, but they may have just got better anyway. And similarly, you know, you may have people who are feeling worse and then got better, or feeling better and then got worse. So that's something you have to be really careful to control with. But certainly, it's a question of huge interest. My wife got COVID last April. She's been suffering from long COVID, and we would love it if this vaccine magically, you know, did actually impact and make her better. But at the moment, I'm not sure. That there's lots of anecdote out there, but as you say, there's anecdote in both directions. And obviously, you need to do a careful trial to rule out things like reversion to the mean, to have to make sure that you can actually genuinely see an effect. So I think it's something that we really do need to do more research into.
Do we know if there is any research going on, Deanan?
Yeah, and Connor, thank you very much for that. And clearly, you know, it's a immensely debilitating situation to be in for not only yourself but many. So there is research that is being undertaken under the auspices of National Institute for Health Research, and this is clearly starting to happen in different centres around the UK. And what I would suggest to you is to ask your GP or any other doctors who you've been under, you know, what research, say that you want to be involved with research that is looking for some sort of mechanism to alleviate long COVID, and to enroll in that research. I realize it may be difficult depending on where you are, but I think we should encourage as many people to engage in research, because then we'll get an answer quicker as well.
Thank you very much, Dean. And Anthony, briefly, if you can, please.
Sorry, very quickly. Yeah, I mean, clearly long COVID has some kind of immunological basis, and there has been some interest in what are called antiphospholipid antibodies as a cause of some of the symptoms of long COVID, and indeed some of the more acute symptoms of people who've been in hospital with COVID. And you could speculate that a vaccination, by boosting other antibodies, may in some way displace or compete with the nasty antibodies. So but it's speculative. I agree with Kit and Deanan that this needs to be looked at very carefully and statistically robustly before we come to conclusions. But I think there is a lot of funding now going into long COVID. It's a shame Kamlesh Kunti is not with us. Maybe if he joins us next week, he could answer this, because he's running one of the very big cohorts.
Thank you very much, Anthony, and thank you for the question, Connor. And moving on now to a question from Tony O'Sullivan, who is the co-chair of Keep Our NHS Public. Tony.
Oh, thank you very much. Thanks again for your hugely important work. Unless the strategy changes, COVID will be a reality for a very long time, with new waves and new peaks in deaths. And in the last few days, there's been a growing call for an official public inquiry. And we agree with that call, but the government has said very clearly that now is not the time. And even if they agreed to it, the timescale for an official public inquiry could be years. But I think that now indeed is the time to learn lessons before tragically yet again repeating mistakes. So at Keep Our NHS Public, we've launched this People's COVID Inquiry, and Michael Mansfield is leading a quasi-legal inquiry, indeed to learn lessons now and to try and save lives. And thank you to Indy Sage for your evidence that we're using and for individual testimony. We've heard important evidence in the first 3 sessions of relatives dying at home, ill for 2 weeks without ever seeing a doctor. GPs really upset and angry that they've been underused and bypassed by instructions to the public to use NHS 111. And positively, on the other hand, we heard yesterday about, on Wednesday, I mean, a voluntary contact scheme which set up effective contact tracing and now trust building in the Sheffield community to mitigate the impact of the government bypassing local public health teams. So my question is, and Christina Pagel has just said that this is the year of the variants. My question is, with coronavirus variants sweeping across Europe and the world, and thousands of new cases still in Britain, and the prospect of further deaths and wider impact, which lessons would Indy Sage feel 1 year on from the first lockdown that you would feel would make the most impact if the lessons were learned now and acted on?
Thank you very much, Tony. I want to fit in as many lessons as possible, but also as many questions as possible following this. So I'm going to allow each of you one lesson that we should have learned from last year. Professor Gabriel Scally.
Thank you for the question, Tony, and thank you for inviting me to give evidence. It was a pleasure to do so. The one thing I think is that the public health system is absolutely crucial in terms of our response. And we have a degraded public health system that has been under the cosh, organizationally, financially, and in terms of morale and in terms of its independence and its voice since 2010. And restoring that system for me would be the priority. And I am dismayed to see the announcement. The government says, we can't wait for an inquiry and we must get on and do things. But they are acting with indecent haste with respect to the public health system. 2 days ago, they published their decision about what would happen to Public Health England. And the announcement of the creation next week, I believe, of the UK Health Security Agency is deeply worrying. And it shows that this government is determined to continue to make major errors. And following on from what Stephanie said, I'm very alarmed that it is to be linked, that it is described as a critical part of the country's security infrastructure and a core part of UK PLC and an engine for the UK's life sciences and diagnostics industry. I really worry about the direction of travel. It's very much in line with something Professor Costello has raised, the issue of the medico-industrial complex taking over control here. And I'm really worried about the UK Health Security Agency becoming yet another governmental secretive security agency. I think the public health infrastructure is under further attack at the present time from this government. And that is one thing, that is my one lesson, that we need to rebuild that and rebuild it properly.
Right. Zubaida, what's your lesson?
I think that without a doubt, a stronger public sector safety net and supporting self-isolation, the two are connected. Financially supporting self-isolation has been the biggest gap in this government's strategy, because the fact that they haven't done that, people have been forced to go to work instead of being safe at home, and that's meant that they have been unwittingly spreading this virus. That should have been addressed, and that would have addressed inequalities in this pandemic.
Thank you, Zubaida. Stephen Reischer.
So let me answer as a behavioral scientist, or rather as a psychologist. My one lesson would be trust the public. A year ago, in fact, just over a year ago, before the lockdown, we started with the notion of behavioral fatigue. The public would not adhere. The public would be the problem in this pandemic. And throughout, the government has treated the public as a problem. It has patronized us. It hasn't been willing to be clear about the dangers. It hasn't been willing to admit its own mistakes. It has blamed us and threatened us with fines. Throughout, it's treated the public as a problem. Now, in the event, actually, one of the few good news stories out of the whole pandemic has been how remarkably adherent the public has been, not because they're obeying the government, often despite the government. So actually the public have done remarkably well. And if people hadn't been as adherent, we wouldn't have been able to deal with the outbreaks. We wouldn't have brought case numbers down. We wouldn't be in the position we are now. But if the public had been supported by the government, and if the government had treated the public as a partner rather than as a problem, we would have done a whole load better, and we'd have saved a very large number of lives.
Thank you very much, Stephen. Sorry, Kit and Susan, I'm going to move on because I want to squeeze in a few more questions. So moving on now to Christine Bundy. Christine, are you with us? And please, could you keep your question nice and short?
I am, and I will. Thank you. Following on from that quite nicely, actually, there's a very worrying narrative across mainstream media blaming people for not following the rules, as we know, despite the ONS showing repeatedly that the majority of people are indeed adhering. We have a minimum threshold of vaccine uptake to achieve community immunity, but we don't have the same threshold for individual protective behaviours. I appreciate that the two are not the same, but my question is, can we model the minimum threshold for each behaviour based on data from countries where they've successfully suppressed the pandemic? And following on from that, can the group comment on the factors that might influence the tipping point where the minority who are not following the rules, minority, small minority, how they might influence the uncertain or the hesitant group?
Thank you very much. Susan, Professor Susan Mickey.
Thanks for the question, Chris. I'm probably not going to answer that very directly, but the first point is that all behaviours are in contexts. And I think there's been a government emphasis on really focusing in on people sticking to the rules, on individual adherence to rules, rather than looking at the context within which behaviour occurs and ensuring the safety of that context. So, obvious examples are people going back into schools, going back into workplaces where nothing's been done in order to make those really safe. And it's impossible for however much you adhere to rules to keep safe in those situations. So that's one point. Another point is that I think, and it's related to what Steve said about how one thinks about people. Are we passive people who just have to stick to these rules? I think there's something like almost 300 different sets of guidance that have come out from different authorities, tiers, home nations at different times. And the rules have become too complicated. There's too many of them. They vary. We just can't remember them all. And I think we need to move away from this sort of approach to one that empowers people and gives them the tools to be able to assess the risk in any situation they're in, which includes different behaviors that they may or may not engage in, different behaviors that other people may engage in the context of that situation, and also equips them as to how to manage that situation so that it's as safe as possible, whether that's in your own homes, on transport, schools, workplaces, other public shared spaces. So I think that's the way we need to move on. And I think it's about having a more rounded and a more scientifically grounded approach to human behaviour, and keeping the spotlight on the context and the situations. They have to be safe as well as people's behaviour.
Thank you very much, Susan. Stephanie, I wonder if I could bring you in here at this point, just on the kind of ethics of the narrative of blame.
I just feel that it's not very helpful, given that people are under so much pressure right now, and all of us are in very different ways, and certainly over the course of a year. It's more about what are we doing to help and support people. And I think part of that is actually better messaging to explain why we are asking to do what we want people to do, rather than sort of blaming, going, maybe that's not actually genuinely possible for certain groups. Let's find out why. So less talking and maybe a bit more listening, because most people don't want to die from this, don't want to get sick from it, and actually don't want to pass it on to anyone else. And we all hate being locked down, and we all want to get back to some sort of semblance of normal life. So given that we're on the same page on quite a lot of the big points, what do we have to do to get us all on the same page to do the tactics part of it?
Thank you, Stephanie. Stephen.
Well, can I come after Carl? Because Carl was going to talk about the modelling bit, which I'd like to hear the answer to.
Okay. Carl first, then Stephen.
Well, the modelling bit actually speaks to Stephen's point before. So a straight answer to the question, can it be modelled? Yes, it can. And that's exactly what we've been doing for the past year. It seems as if we are behaving as a population as extremely good estimators of the prevalence of infection, and also very compliant in the sense that we tend to reduce our social contact rates when the prevalence rises. So that just mathematically endorses, if you just fit the data, and by the data I mean both the epidemiological data and measures of retail activity through Google Mobility or the Department of Transport car use, you can actually quantify and model our responses as a population. And I repeat, we are remarkably good at estimating and responding to that. Does that help with personal risk and decisions? And if it did, would one need quantitative thresholds for not doing this and not doing that? Absolutely. We've seen lots of examples of that. For example, on both the occasions where there were questions about reopening schools, the Independent SAGE has modelled that very carefully and provided clear quantitative criteria in terms of the number per 100,000 of new cases as a traffic light set of thresholds to decide whether you should, or whether, if you're a head teacher, whether you should reopen schools. I think a very similar approach will become more prescient during unlocking, and that brings me to two final points. The first point is that it is interesting that there are no quantitative criteria in the roadmap, in the government's roadmap, and you have to ask yourself why. And reading between the lines and discussing with people responsible for sort of implementing the roadmap, I think that the messaging for the population in terms of national responses is deliberately non-quantitative, so they can just review, has anything awful happened before we move on to the next phase of unlocking. However, there is an appreciation that in terms of local action, that's going to have to be much more quantitative. It's going to require lots of careful assessment of what's going on in your local authority, so there can be targeted local responses. And just to slip in, of course, the most important one of those is backward contact tracing, supported isolation, which will be local. And the final point, so why have we fared badly in relation to other countries? The mechanism that has suppressed viral transmission in other countries does not depend upon certain socio-behavioral responses. It depends upon contact tracing and isolation. So we've divided the ways in which you suppress incidence into three. It's contact rates, transmission risk, and the mean period of infectivity. And it's that last one which is the most specific target for effectively reducing community transmission. And that depends upon backward contact tracing and local supported isolation. So that's where the local action has to be directed. One little twist there, it'll only work when the prevalence is sufficiently low. So that's what I think the government are waiting for, but they won't say that out loud.
Is it low enough now, Cole?
No. They say 25 per 100 per day new cases, which is consistent with our sort of rough threshold of 10 per 100,000 per day new cases, where it becomes logistically feasible to deploy surge testing and supplement and local public health teams to do that. So that it just can't be done at this stage. But by the summer, then there is a definite possibility that it could be done.
Thank you very much. And Stephen, you wanted to follow on from Carl.
Yeah, so it's a wonderful question, Chris, and it addresses my personal bugbear. So I'm going to do a bit of a rant. I'm not sure whether I will get to full Costello, but it's going to be a bit of a rant. So let me start off by saying that actually there is a rather simple answer to your question about the tipping point. And that is that a lot of psychological research shows that people's willingness to act on their personal attitudes depends upon whether they think that they accord with social norms or not. So if people who are non-adherent think that it's normative, they'll do it. And if they think it's non-normative, they won't break the rules. Now, the great paradox is this. The great majority of people, as you said, are adhering, 80, 90% or more in most areas. Okay? But most people believe that other people are not adhering. About 80% of people think that others aren't adhering. So why do we get that remarkable discrepancy between what's happening and what people are doing and what they think others are doing? And the answer to that is very much to do, first of all, with the government's own blame narrative. It keeps on telling us that everybody else is breaking the rules, and it's the fault of people breaking the rules. And secondly, the media, going by the old principle of if it bleeds, it leads, far prefer a story of a house party or a rave with 100 people than 10 million people staying at home and doing the right thing. And every day throughout this pandemic, virtually, and I'm not alone in this, I've had the media saying to me, are the public adhering? Are they still going to adhere? I had that question today from The Guardian. And time and again, I try to say to them, look, number one, the public are adhering, but number two, the problem isn't the public. It's what Susan says. If you're going to ask why are people going out, it's because they're going to work. Why are they going to work? Because their bosses are forcing them to go to work and not allowing them to stay at home, or they don't have the facilities to work at home. What do you do to change things? You change the duty upon employers to let people stay at home. You provide the resources so people can work at home. You don't talk about the public. So this is an appeal to the media, and it's an appeal to the government. And it's to say, be accurate in your reporting. It might not be that exciting. It might not be bleeding. It might be dull, but the true reality of this pandemic is the mundane, dull, heroic compliance. And if we get that story out, then the minority who don't adhere will realize how anti-normative their behavior will do, and it will tip things so they do it even less.
Thank you very much, Stephen. That was a particularly fine rant. I'm going to squeeze in one last question. It comes in from Sophie Payne-Gifford. Sophie.
Hiya. Can you hear me?
Yes.
My question is basically, what is your outlook for the winter? Background, I'm a researcher, I'm a social scientist who would, pre-COVID, interview people face-to-face in small meeting rooms with no window or door open. What plans for fieldwork should researchers be making, or not? Or anyone who wants to spend any time indoors with anyone.
Thank you very much, Sophie. Do it all outside. Who would like to take Sophie's question? What are we going to see in the winter? A bit of crystal ball gazing here, but what's the direction things are going in, do we think? We've touched on that today, but would anybody like to elaborate a bit?
I think Carl,
what do you predict?
Not Steve. We don't want another rant.
Carl, what would you predict is going to happen this autumn and winter?
Well, if you want our predictions, then you can go to the UCL long-term forecasting site, and you will find a very optimistic prediction there, with a very low prevalence endemic equilibrium. And that's predicated, again, upon exploiting the seasonality to bring the prevalence down sufficiently low that then we can use proper contact tracing and isolation. So if everything goes okay, and ideally, then you could be looking, I repeat, at a very low prevalence equilibrium by next Christmas, to the extent, and I said this last year and was completely wrong, but I'll say it again, to the extent it may not even be in the news. This contrasts with long-term forecasts from Warwick and Imperial that are substantially more worrisome, with many, many thousands of deaths. The Imperial group are the most pessimistic and predict a surge in autumn, early autumn. The Warwick group have a range of predictions, and the key thing that differentiates between all of these predictions, ranging from the worst, which is the Imperial, to the most optimistic, which is the UCL, which includes a lot of mitigated responses, it has more detailed behavioral modeling in it, is this theme of seasonality, which I keep coming back to. So the Imperial group only allow for 10% seasonality, when the Warwick group include 25% seasonality, or a suppression in transmission risks in the summer, allowing us to get on top of it, exploiting the benefits of population immunity due to vaccination. Then their forecasts become much more palatable. When you actually use the estimated seasonality based on what happened last year, which is actually up to about 50%, then it's looking much, much more optimistic. So that's my crystal ball gazing.
Thank you very much, Carl. We'll fit in some other brief responses here. Gabriel, you wanted to say something?
Well, I've no idea who's got the best crystal ball, and I think it's probably not a good use of time to try and work that out. What we do know is that the future is uncertain, and the future is uncertain because of a whole series of factors, including this government's behavior, including the virus and its behavior and the development of variants, the level of vaccination that will be achieved across Europe and across the world, highly variable. So the virus, and we still don't know the full story of the natural history of this virus. So the only thing that I can say to you is it is not predictable with any degree of certainty, and therefore you've got to make a plan that is a flexible plan, one that will enable you to achieve your goals, whatever they are, but to achieve them whatever the scenario turns out to be. So you talked about interviewing in rooms with doors shut and windows open. Well, I would strongly urge the government to invest very, very substantial amounts of money in improving the ventilation in all workplaces and making sure that it is improved in all ventilation in all places and effective in all places. I would absolutely urge us to continue to observe social distance where that is required and where it's necessary, which at the moment is everywhere outside your small bubble. And the autumn, we should, I hope, be in a better position, but we must not take it for granted or put all our bets onto one square on the roulette table, because we will get it wrong. And we've got everything else wrong about this virus, and predicting its development and its passage and its history. So the only thing to do is go back to the basics, and the basics are about distance, about ventilation, about keeping yourself safe, about the country avoiding international travel so we don't import variants, and let's get everyone vaccinated across the world as soon as we possibly can.
Thank you very much, Gabriel. I am going to draw this briefing to a close, but not before Sir David King has a chance to say a few words. Sir David.
Thank you, Alice. I will be quick. I want to first of all say The very good news is that each of the groups over 60, as Dr. Kit Yates has expressed, are now over 90% vaccinated. That's an enormous success, and we should really attribute that success to the NHS and the GPs in their public service. Just amazing how efficient that has been, and that is a real tribute from all of us. What do we need to watch out for, and what will we be making sure that we keep an eye on? And that is the variants, the South African variant and the Brazilian variant in particular. But that South African variant now at 400, we believe, in the country. We need to keep an eye on how that rises as we move forward, and particularly as lockdown changes are made going forward in time. I think my worry, as always, is that we have seen the government slip in under the guise of this extremely costly in lives and economy outbreak in the world, but particularly in this country. We've seen this government take advantage of that to privatize a major section of our health service. And I think if we now want to draw a comparison between the efficiency of the private sector against the public sector in the health domain, and let me stress, I'm only talking about the health domain, then simply look at the lack of success of the find, test, trace, and isolate system that has been entirely run since May in the private sector. We haven't yet delivered the capability at any level of this outbreak to separate out the people with the disease and those been in touch with them from those of the healthy members of the population, which would have allowed our economy to proceed and would have kept the death rate down to a very small fraction of where we are today, and of course, the number of long COVID cases. The UK Health Security Agency privatisation recently announced is yet another peg in that privatisation process of our National Health Service, slipped in the middle of a pandemic at enormous cost, as I've said. Now, the question that Tony O'Sullivan asked was, what are the lessons we've learned? Surely that's the major lesson, that the health of the country is best served through our wonderful public health service that was wonderful before it became starved of funds. And that happened at just the worst time as we hit this pandemic. But thank you. I've had my little rant, but I do want to come back and congratulate the National Health Service and the general practices for the efficient rollout of the vaccination.
Thank you very much indeed, Sir David, and thank you to all our independent SAGE scientists who work tirelessly to help the public navigate through the pandemic. As well as our weekly briefings, Independent SAGE has produced many reports dealing with all sorts of different aspects of the pandemic with expert analysis and advice. All of those are available on the website along with details of the scientists. And I must also say thank you to our special guest, Stephanie Hare, for joining us today. Thank you, Stephanie. Thank you for your questions today, and thank you for watching the briefing. Do follow Independent SAGE on Twitter and Instagram if you don't already. We'll be back same time, same place next Friday. Stay safe, keep well. Thank you, everyone.
Thanks. Bye.
Bye.